There we go. We are now recording this talk. So welcome to this evening's talk. We are joined today by two speakers. So we've got Dr. Caroline, Dr. Caroline Ackley and Janani Murugesh, who is one of our students who are going to be delivering the talk today. So the title, as you can see on the screen, is What in the World is Medical Anthropology and Why Should I Care? Just to say, while we're going through this lecture, if you have any questions during the lecture, if you can put them into the Q&A section at the bottom of your screen, you should be able to see that. And Caroline or Janani will be answering those at the end of the talk. So we'll have a bit of time for question and answer at the end. During the talk, there may be some links going in the chat. So just keep an eye on the chat as well for any links that are delivered in there through the presentation. So I'll just give an introductory. So tonight's lecture has been delivered by Dr. Caroline Ackley and Janani Murugesh. Dr. Ackley holds a PhD in medical anthropology from UCL and has worked in the Horn of Africa since 2009. Her current research is in Sudan on the neglected tropical disease mytoma. She's previously conducted research on HIV in Brighton, child and maternal health in eastern Ethiopia, and women's life force development in Somaliland. She teaches on the Global Health MSc and supervises a PhD student affiliated with her NTD research, as well as an independent research project student, which is a fourth year medical student at BSMS.
And Janani, she's one of them.
Is a current fourth year medical student at Brighton and Sussex Medical School and has an MSc in International Development and Health. In her fourth year independent research project, she is working with Dr. Caroline Ackley as part of the NIHR grant. They connect the experience of skin-neglected tropical diseases for women and its intersection with vulnerability. So now that I've introduced you, both of our speakers to the talk this evening, I'm going to hand over to them.
Thank you. Welcome, everyone. It's really intimidating and exciting to see that there's 40 people here. So 41. So we're really excited to talk to you today. So Janani is going to put a link in the chat, actually. Do you want to explain what the link is for?
Yeah, it's just during our talk, we're going to have some interaction. So please interact. And it's just going to be on Menti, which I think a few of you have used before with BrightMed stuff. So I've put the link in the chat. And I'll also put the code in, and if you wouldn't mind joining, and then we'll signpost you to when you should go on to Menti later on in the talk.
And there are other so we don't need Menti now. We'll tell you when to go ahead and open it in your browser. We'll tell you when you need to start answering questions, because if you look at it now, you'll be like, what are they talking about? But there are other places where we definitely want you to get involved, and you can write because I know you can't speak to us, we can't hear you. So if you write your answers in the Q&A, we can somehow read them out a little bit, and then hopefully that will allow us to engage and interact a little bit more. We'll see how it goes. Hopefully it works. I think that's kind of our housekeeping. Is that right?
Yeah, definitely.
Great. But we want you to interact. We want you to think. We want you to engage. So this shouldn't just be listening to us.
It'll be more fun that way as well.
Yes. So I want to kind of show you some of these images to start with, to maybe set the mood, give you a different vibe than you might be used to for some of these sessions if you've been to several before. But I'm wondering, does anything on this page look familiar to you? Whether in your experience of in your interest in maybe getting into healthcare or kind of some medical training, or if you've ever gone to a hospital. Just take a moment to look. There's obviously a theme across all four. And I'm hoping that what you're thinking is, oh, that snake in the scepter actually looks very familiar. That, this is a symbol that pervades medicine, but it's actually a symbol that has a long history going back to Greek times and Greek mythology. And it's something that kind of, the ancient god of healing, to the goddess of health and cleanliness, hygiene, right? But then we look at it now and we can see this in a hospital. So I want you to think about kind of the symbols and meaning that pervade our lives, that we might take for granted, and that will hopefully get you in this kind of anthropological mindset. So maybe you've heard of anthropology. When I was your age, I had never heard the word anthropology. I first learned about it when I did my master's in my mid-20s. I'd never heard about it beforehand. So some of this might be new for you. You guys might be much more advanced than I was, but there are kind of traditional branches of anthropology. So you're probably most familiar with this socio-cultural model. There's linguistic anthropology, which looks at language and discourse and the words we use and how we use them and why we use them. Material culture looks at literally objects and materials. And then biological anthropology actually looks a lot at animals and primates. And these all relate to medical anthropology in some way. So we can look at the culture of a hospital. What's the culture of the doctors, and how does that influence the type of care you get? What kind of language is used to describe diseases and illnesses? The material culture could be medicines are literal objects. They have certain colors. So if you take a red pill, you might feel different than if you take a blue pill, for example, or you might perceive risk about that pill differently, and that could affect what it does to you and for you. And then biological anthropology, we can all think about, where we've come from, but also perhaps even animal testing. But more specifically, we're going to talk about medical anthropology, which I'm just going to read it out because it's quite a long one, but it's really helpful. It's a subfield of anthropology that draws upon the social, cultural, biological, and linguistic anthropology to better understand those factors which influence health and well-being, the experience and distribution of illness, the prevention and treatment of sickness, healing processes, the social relations of therapy management, and the cultural importance and utilization of pluralistic medical systems. So that pluralistic medical systems is a really fancy way of saying, you might go to the GP, you might also go to pray to get better, you might use homeopathy to get better. We live in multiple systems, but sometimes we don't always acknowledge it. You might just have your mom's chicken soup. Yeah, hopefully that's a really good grounding definition. If you have a question, put it in the Q&A, and we can always come back to it at the end. Or if it's I can't move on from this, put it in there now. So I'm just going to open it up. Okay, no questions. All right. So some key approaches within medical anthropology. We have ethnomedicine. So that's where you use traditional medical practices concerned with the cultural interpretation of health, diseases, and illnesses that address the healthcare process and healing practices. So basically, we can think about this a little bit about homeopathy. So traditional medical practices could also be something like bone setting, which might seem far removed from us, but actually it's not. I mean, this was happening in Ireland not too long ago, for example. And then how does that address these healthcare processes? Then applied medical anthropology. So that's the application of anthropological theories and methods to health interventions. So I think one thing that Janani's IRP research that she's going to present later takes, although it's very theoretical, she's taking it in a very practical sense as well when she's applying it to the skin and TDs. And then there's critical medical anthropology, which is kind of where I am really influenced and come from in my thinking as a medical anthropologist. So that's where you think about not just disease and ill health or well-being, but you think about what are the influences of power, structural violence, and inequality on experiences of illness. So we know there's just drastic inequity in healthcare, and critical medical anthropology says you can't just think about a singular disease. You really have to put it in this world context. But we use very ground level ethnographic approaches, which I'll describe in a bit. And this is a really powerful quote from me, hopefully for you as well. And Paul Farmer, he's recently deceased, but he's so influential in medical anthropology. And he was a trained doctor. I highly, highly recommend just Googling him and just learning about him. Inequality manifests as sickness. That seems really obvious, doesn't it? So what is structural violence? So that is sort of by saying, that's a really great question. That's basically when you have the different kind of layers of power and structures within, like structures of power that you can't really break free of, for example. So, we're thinking about like let's say social mobility, social inequity. We like to think we have a lot of social mobility and we can change our social class, but it's actually really, really hard to do that, right? Like if we think practically, and how does social class impact our experiences of health? Or if we look at political structures, that's a type of structural violence. Political structures can inflict violence onto people based on their kind of lack of care or their oversight or just blanket policies that don't actually affect people at the ground level. So there's a lot of ways of looking into it. So hopefully type in if that helped or not. And then we can always come back to it at the end if it didn't. So how do we do medical anthropology? That was like the quickest introduction to medical anthropology. So now I'm going to tell you how we do it. So I'm giving you some examples from my own research. So as Claire was saying, I've done research in the Horn of Africa. So I did, for my PhD, long-term ethnography. So it's actually a really big gift to be able to stay and live with the community for as long as I got to. So I did 18 months in this community in Somaliland. And what I did was I basically lived with people. I spoke Somali. I dressed like people, very obviously. Everyone laughed at me, and you might be laughing right now. And I followed local customs. And we had this continuum of participant observation where there's times when you do participate in activities and in local customs. There's times when you just observe and you sit back. There's times when you're a bit of both. So I, for example, attended these like marriage classes for young unmarried women, and I was a participant observer. So I was a student. It was called Kois Cobb Family and Marriage Classes. I was a student where I learned how to become a good wife and mother, but I also observed everyone around me. So for example, one time we had a sheikh come, and he was a really powerful sheikh in the community. And you can see the women didn't have their faces covered. The second he came in the room, all the faces were covered. Women that don't wear gloves wore gloves. There was not an inch of skin showing. And I was just trying to observe that while also participating as a student. So it's this continuum of back and forth. And we call that ethnography. And that's one of like the cornerstones, the foundations of anthropology. Then, maybe, there we go. We have something that you're probably more familiar with, qualitative methods. So that's things like interviews and focus group discussions. And focus group discussions are literally group interviews. So these are some examples from research I've done in Ghana and Ethiopia. That's one of my colleagues in Ethiopia. He's holding his voice recorder, being very serious, interviewing a mother with her child. So interviews, we often think are like very almost clinical, like you're in a room across from a table, but actually the real world, that doesn't work all the time. It's not practical. Like, could you imagine this mother sitting down in a room with her child on her for a half-hour interview? No, we had to be like on the go, on the spot. So I wanted to really show like this field in Ghana. We were interviewing farmers as they were farming, or we were speaking to people at this cell phone shop as they were queuing to get their cell phone repaired. Interviews aren't always that image that you have. They can be very different. Then we have participatory methods, which I think are so fun. And I don't know if the fun of them really comes across in these photos, but this is again from Ethiopia. So this is from, we did photo voice, which is where you get like maybe 8 to 10 people, and it's kind of like a focus group, but you actually then teach them how to use a camera if they don't know how, or some places they just know, it's easy. You talk about ethics of taking pictures, and you give them a topic. So this is an example of, we were getting women that were leaders in the Women's Health Development Army, which is like a community group in Ethiopia. We asked them to take pictures of what made their children healthy and strong, because we were doing a study on child death, and it was horrible and depressing, and the community really didn't like us, which I'll talk more about later. But we wanted to also, the medical anthropologists amongst the team wanted to shift that narrative and say, you know, there are some things that you do right. We'd like to identify that, champion that, and hear that. And then we want you to teach the community what's working well, rather than this focus on the negative and on death. So we gave the mothers cameras, they photographed things. So it'd be like some of the moms took pictures of injera, which is like this bread made of teff. It's kind of fermented and sour. One mom took a picture of her breastfeeding her child. Another mom took a picture of her bathing her kids. And then these were all really good examples of health, hygiene, nourishing food. And they got to speak to the community about it. At the same time, we ran like a basic clinic for kind of health checks for people that normally wouldn't come in for like blood pressure, for example. So it was kind of a twofold thing, just to show in global health, you might do both things. You'd work with the clinician, but you'd also do your kind of fun medical anthropology bit. I'm just going to throw around some names of participatory methods that I'm happy to talk about at the end. So there's stakeholder analysis, where you basically identify who's important in the community. Asset mapping, so you might identify people, places, and things that are assets to the community. Workshops of knowledge co-production is where you really work hand in hand with the community to co-produce solutions, not just hierarchies of knowledge. And this I'm really passionate about. So please ask some more questions on these participatory methods. So why is this relevant to me? Who cares? That's the big question you might all be asking, because you're thinking, I probably just want to do surgery. I want to be a midwife. This doesn't matter to me. Well, it does. So we have these concepts in anthropology, which Janani is going to show in practice when she speaks. But for example, emic versus etic, the insider perspective and the outsider perspective. This is so important. Janani, do you want to say something on this, or was it later? I'm trying to remember. Later. Okay, good. So just think, let's say you're the healthcare provider. You have your perspective. The patient has their perspective. The two merge and form a reality. Very basic, but very important. Disease versus illness, right? So a patient comes in because they're suffering an illness. They come in because they say, my toe hurts, my tummy hurts, my head hurts, my eye is watering. They're suffering, but the doctor diagnoses and treats a specific disease. So the patient comes in, and sometimes once their disease is named, there's a relief for people. So we often hear this about cancer diagnoses. People have these mystery symptoms. They come in, the doctor tells them, actually, unfortunately, you have cancer. But then the patient actually has a way forward. They can address this now, right? So when physicians dismiss illness because disease is absent, they fail to meet their socially assigned responsibility. I would say a really good practical example of that is endometriosis. We know women's pain is there, but doctors really fail to identify it. And chronic pain, for example, is another really good example. I don't have time to go into the book that I'm thinking about, but if you want to get a different perspective on disease, illness, and the ways in which the patient comes in with an illness and symptoms, but all the doctors they interact with have a different perspective as well, there's this book called The Body Multiple by Anne-Marie Mole. I'm going to type it in the chat. And what's beautiful about this is it's really bizarrely written. Literally the top of every page of the book is her ethnography. So the data, the story, and the bottom is her theory. So if you're like, I cannot handle this theory, great, read the ethnography. You don't have to read the theory, which I think is totally wacky, but amazing at the same time. So we've also got this idea of explanatory models. Basically, this came out from Kleinman again, who we saw on the previous slide, that we need to think about more than cultural competency. He came up with a set of questions that you can ask in an assessment where you can find out what actually matters to the person so that you can effectively treat the patient better and create rapport in a relationship with them. Janani, do you want to say something here?
Yeah, I just wanted to relate what Caroline's been saying back to things that you've probably learned during other Bright Med sessions, like when you've learned histories. So a big part of a history taking is ideas, concerns, and expectations. And that is the real life application of an anthropological technique of trying to get your perspective and knowledge as a doctor to meet the ideas and expectations of the person who's sitting in front of you. And so I wanted to put it into kind of that practical aspect that you've already been practicing within your Bright Med sessions. But I also wanted to talk along with what Caroline was saying. There's a lot of diseases that are treated based on the experience. So like chronic fatigue, like fibromyalgia, the way that they are looked at is not, here is the disease process, we are going to treat that disease process. It's looked at like, this is how this specific person is experiencing all of these symptoms. So let's try and figure out how to alter that experience. And there's a lot of conditions that are now becoming more like that, especially within the UK. And I just wanted to end on like, I was once on clinical placement with a plastic surgeon who did burns, specialized in burns, and he was saying like, even if he did the most beautiful surgery, the most amazing sutures that he's super proud of, but the patient has had a really bad experience throughout that process, the outcomes for him are worse than if it's a very average procedure. He wishes he'd have done a little bit better on the aesthetics of his surgery, but the patient has had a really great experience. And so it shows how it is really important as a future healthcare professional to address what that experience is.
Yeah, thank you. Those are really good examples. And while you were speaking, I was thinking of another example of structural violence that, again, I think especially in global health, you have to take into perspective, which clinicians, in my experience, don't always, but that's why you need medical anthropologists, to be colonialism. What is a legacy of colonialism, and how is that in people's mentality and in the systems and structures in which they live that impacts their health and well-being? So that's another example. So hopefully the person that asked that question, we'll see. Okay. So I'm hoping you'll type in the Q&A box what kind of bodily processes have become medicalized. How? We give you some examples here. How have they become medicalized? There is no wrong answer, I promise. I don't know all the answers.
I can talk about an example while waiting for...
Yeah, go for it.
Because I'm on my obstetrics and gynecology placement at the moment. So pregnancy and childbirth and it being medicalized is a huge thing that I'm witnessing. And just today, there was, I think the stats, I'm in Chichester at the moment, and the statistics of how many mums choose C-section over vaginal deliveries is, I think it's like 30% of mums are choosing C-sections. And so it's really normalized that is a part of childbirth. Whereas before this medical advancement, we wouldn't have had that. And so,
yeah, well, I think that's a great example. And I would say, so I had a child during the pandemic, and it was really my first child. So it was really interesting because there is also this sort of like moral hierarchy about having a physiological natural birth versus having a highly medicalized birth, and kind of within groups and families and friend groups about it. It's also really interesting how we conceive of natural childbirth. So in some countries, it's if you just have a vaginal delivery. In other countries or other cultures, it's you can have all sorts of interventions. So you could have an epidural, but it's still a vaginal delivery, and that's still a natural childbirth. Whereas in other countries, you have to have a completely unmedicated vaginal delivery for it to be natural. So there's this idea of what is a natural childbirth. And thank you, depression and happiness. Excellent. So taking antidepressants or hormonal therapy. Excellent. So that actually leads us really well into our next slide. Did anyone else want to say any examples of yeah, great. More people are getting help with depression and other mental health problems because they are being more recognized with treatments. Exactly. So we're able to identify these things more. So they're, in some cases, they're becoming more medicalized, right? I would say, in my experience in global health, some of the diseases that we see in Africa, so let's say like Alzheimer's, it seems like there's a spike in Alzheimer's or a spike in certain diseases, right? But it could also be because we now can identify them, and we have the technologies and tools to identify that there, not just here. So there's an increase, but that's because we can identify you have Alzheimer's, not just you're growing old. Okay, perfect. So did you want to talk about what are the risks and benefits to medicalization, Janani? Or we can just leave that as food for thought, maybe? So again, we're thinking about medicalization, but what are the risks and benefits? Take that away and think about it. And great that you guys mentioned psychology and depression. So there's a lot that we can say about this. So in my research in Somaliland, I was teaching as well, and it was really common during exams for students to have jinn possession. We might call that an anxiety attack, but there it was a very serious jinn possession, and they actually got out of exams, and we get taken home. So from my culture, I was like, come on, guys. But everyone else was like, oh my gosh. In Somaliland as well, there's religious healing centers called alages, where instead of getting kind of formal psychiatric care, you get religious healing, which is, I think it was written about in The Guardian or the BBC not too long ago. It's actually quite horrific what happens here. It's not just like going to your mosque and praying. It's almost like sensory deprivation, and you're isolated on your own and you're chained to a wall. So it's quite grim and very ineffective. There's an example, we've spoken about Arthur Kleinman a lot. So he's actually a psychiatrist and a medical anthropologist. He's got this really cool book, I'm going to type it in the chat, called Weideman Barbecue. And that's by Kleinman. And he gives the example of a Vietnam vet who comes to him for psychiatric care. He's presenting what would traditionally be called PTSD. So when he was in Vietnam, he killed somebody. And he has ever since then really, really struggled with it and hasn't been able to kind of live his life in the way that he wanted to. It's affected his familial relationships, affected his work. And we would classically present that as PTSD. But Arthur Kleinman said, yes, but it also sounds like he was suffering from a moral dilemma. So in the cultural context of the war and of the side of the war he was on, it was morally acceptable to kill somebody so you didn't get killed yourself. But once you move away and outside of that culture, how do you reconcile, cope, and live with that? And this man couldn't. And Arthur Kleinman said, it's okay that you couldn't. And we need to talk about why that's okay and why you can't cope. Rather than giving it not a simple label, but a label of PTSD, we need to also talk about this moral dilemma that this man is having. There's so many examples in this book, very accessible and very fascinating. So you guys have already answered our question that we were going to ask, which is depression universal? How do people experience stress and hardship in different places? I think some of you have already answered that. Does anyone else have any thoughts on it? Or Janani, did you want to add anything?
I guess I just wanted to add about the global mental health movement, but also how a lot of our psychiatry and psychology knowledge is very based in allopathy and very based from people who are from Europe and America, and there's a lot of knowledge on psychology and psychiatry that's only just being brought to the global forefront from everywhere, and therefore there is lots of knowledge that we're still missing to really understand that psychology and psychiatry experience. And that goes along with the colonialism within global health that Caroline talked about. And so as you go through your healthcare career, it's important to always keep that in the background. Yeah.
Great. So we don't have time to go into these other examples. So organs and commodified bodies. I had alluded to an example in Ethiopia. Basically, we were doing something called minimally invasive tissue sampling on deceased children under 5 and stillbirths. It was a multi-country Bill and Melinda Gates funded study. It's still ongoing. I had a lot of moral issues with this study. It was really difficult. And the social science team I was with, we also found it very difficult. But basically what I want to say is that we were like the clinicians and the histopathologists and everyone were taking these tissue samples, studying them, trying to find leading and underlying causes of death. Scientifically sounds really great, but culturally hugely problematic. We were seen as vampires, stealing blood and harvesting organs. So I wrote a paper on this. If you're interested, type it in the chat and I can tell you, like, send you a link to the paper that I wrote with my Ethiopian colleagues. Yeah, but there's so much to say about this. And then we also have therapy and enhancement. We have a lot to say about this, but we're running out of time. So again, type something in the not chat, Q&A. We can come back to this. But in short, like somebody with a cochlear implant, that is so normalized now and a beautiful medical technology, but also a bit of a cyborg, which is very cool. All right, and I just wanted to give a shout out to this final kind of reading called The Spirit Catches You and You Fall Down. This is, again, another really beautiful text. And it's not written by a medical anthropologist, it's written by a journalist. So it's, again, very accessible. But it's a story of a Hmong family that moves to the US. One of the daughters has epilepsy, but in Hmong culture, it's literally described as the spirit catches and you fall down. It's somebody has been captured, their soul has been captured by a spirit. So how does this cultural belief of a soul being captured by a spirit interact with kind of biomedical society in the US that would call this epilepsy? And what happens to this child? It's a really beautiful book and I really recommend it. All right, Janani.
So I know Caroline's spoken about a lot of global examples of medical anthropology and all of the amazing research that she's been involved in. But I thought I might just bring it back to NHS examples, because if a lot of you are planning to work in the NHS and graduating here, it's important to know that you can participate in anthropology locally as well as globally and within your day-to-day practice as well. So all of these examples have come from a UCL anthropology blog, which I'll put a link to later, but it's really accessible and really great, a great read to kind of start your anthropology journey. Caroline used to lead it, so it's very good.
It's very random. Janani's like, I found this great blog. It's like, I used to run it. Oh my God. Yeah.
So one of the examples is rapid ethnography. So Caroline spoke about ethnographies and a long-term one, but this specific example happened for 4 months, and it looked at the psychosocial factors of co-production, which means developing resources together, like Caroline already mentioned, of mental health services for marginalised groups in East London or in London. And what this rapid ethnography did was, over 4 months, it did interviews, it did observations, all of them methods that Caroline showed us in a global context, but in an NHS context, to understand how marginalized groups can have better mental health services, especially as we know there's a huge socioeconomic inequality when it comes to mental health outcomes. Then when the second example is participatory photography projects. So this was a really nice example of how people who are living with multiple health conditions manage to communicate instead of using words to communicate how living with multiple health conditions affected them, they used images to communicate that, and that became the start of a participatory project of understanding how to adapt health services, but also just understanding what the experience of living with multiple health conditions is. And especially as we are living in a aging society, this is a huge part of your medical career as you'll go on. And finally, I just wanted to note on reflexive practice. So this is a huge part of anthropology, but also a huge part of being a healthcare professional. And you'll be asked to reflect from the day you start medical school till the whole way through your career. And it's so important because it shows you, both if you're a researcher and as a clinician, where your own biases are, how your own opinions are going to affect either the research you're doing in an anthropology context or the treatment and care that you're giving your patients. And so it's a skill that's used within both fields, and so a great skill to manifest as well.
Yeah, excellent. I feel like I have so much to talk about on this. I love it. Thank you.
No problem.
So now we're just going to kind of transition. Hopefully you have a much better understanding. What is medical anthropology? What do we do? How can you think about it in some real case studies and examples, right? Even NHS examples. What's going on in the department? So if you were to come to BSMS, how might you interact with global health and medical anthropology? I'm saying global health because I'm from the global health department. So how might you interact with medical anthropology? Well, in the global health department. So one study that we have going on right now, it's called the NIHR Global Health Research Unit on Neglected Tropical Diseases. That is literally a screenshot from our website. You can just type that in, you will find it. A little like bragging, that is Professor Gail Davey. She is the head of our department, one of the PIs on this big research study, and she has an OBE, so you'd be like brushing shoulders with really important, knowledgeable, influential people, and she's great. So basically, this study is looking at 3 neglected tropical diseases in 3 different countries. So it's looking at podoconiosis in Ethiopia. It's looking at mycetoma in Sudan and scabies in Ethiopia and Rwanda. We're happy to answer a bit more about what podoconiosis is, mycetoma, or scabies. And we have different ways of studying this. So there's mechanisms of disease, geospatial mapping, diagnostics and drug development, and implementation research. So for example, we're also looking at homeopathy. What are natural herbs grown in Ethiopia that might be able to address podoconiosis? Geospatial mapping actually leads me to the next slide perfectly. So let me go there. So in geospatial mapping, we had an epidemiological component, and they identified that although mycetoma typically presents more frequently in men and their legs and feet, and our study site, which I've circled here in Sudan, in Sinar, women tend to have higher rates of infection in their hands. So I think that leads really well into Janani's component. I'm happy to talk a lot more about this study, although I have to say, given what's happening in Sudan, we don't actually know what we're going to be doing in Sudan. So if you want to ask more about this, I'm happy to talk about it. But I think this really segues really nicely into Janani's personal research to show if you come to BSMS, you're actually contributing to world-class leading research with someone like Gail Davey. You work with me, but you're rubbing shoulders with Gail. It's amazing. So let's hear more from Janani.
It's amazing to be rubbing shoulders with you as well, Kyle. And so, like as Kyle was saying, I'm going to present a little bit of my research project as an example of how within medical school you can also get involved with medical anthropology. It's not as cool as going abroad and really immersing yourself in another community, but you can do it from your computer and do a literature review as well, which is as important, but also maybe not as fun. So my research is on the experience of vulnerability and how vulnerability is constructed for women with skin-neglected tropical diseases. And I'll explain a little bit more about what that actually means in the next slide. Sorry, thank you. So skin-neglected tropical diseases comprise of 10 different infectious conditions, and they're categorized by the World Health Organization, not because they all have the same pathology, but because they all have skin manifestations of the disease, and they also are all neglected and underfunded and marginalized when it comes to research and treatment. And that's why they're such a huge part of the World Health Organization's development goals for the future. So within that, we looked at women and how women are marginalized within the treatment and within health facilities. This is a global phenomenon, especially as a lot of anatomy and physiology has come from men's health as a basis. But specifically with skin-neglected tropical diseases, with drug distribution and within actual production of the health facilities, women are often not included in these processes. And so within that, we also wanted to see how women are described within the current literature. And we found that often women and groups with protected characteristics in global health literature in general labeled or characterized as vulnerable, so are seen as vulnerable groups, or they because they have an SNTD are vulnerable. And so we wanted to really explore what does that actually mean, and why are people being described as that. And so that was a big part of the research as well, because there's a huge danger in if you do label a specific group or a specific condition as vulnerable, that people don't get the agency and don't get their voice heard when it comes to actually making treatment decisions and making services to fit them. Instead, it's paternalistic treatment that is more likely to prevail. So other people say that this is the treatment that you need and therefore you take it. And so it's important to change that narrative. So I quickly just wanted to show you this slide of statistics. So this is from the Global Burden of Disease study to show the disability adjusted life years, so the years lost due to ill health because of the different neglected tropical diseases, and it's split into gender and different age categories. But what I also wanted to say in this graph is that it's really important to take quantitative data, so numbers and figures, in the context that you see it in. So within skin neglected tropical diseases, a lot of the information might be taken from health facilities. And so you only get the information from people who actually attend the health facilities, and not everyone else who's not been able to access that or has been excluded from them facilities. And the same with data from mass drug administrations. So sometimes that happens in schools, and sometimes girls and women are underrepresented in the education system where the mass drug administration is happening, and therefore you don't get that data. So it's just important to have that in mind when you're looking at statistics. So I might just quickly go into the next slide, if that's okay, Caroline, to do a little bit more. So we talked a little bit about what is vulnerability as part of the research, but I wanted to get everyone else's thoughts on what you think vulnerability in health is. Yeah, so if you wouldn't mind putting in the chat, in the Q&A, what you think vulnerability is, and to help you address that, think about who might be conceptualized as vulnerable and who is not vulnerable, because if there is someone who's vulnerable, there must be not vulnerability as well to exist. Why are people vulnerable? And then who has decided what this construction of vulnerability is? Yeah, so I'll give it I think
a great answer here. Lack of access, full understanding of their own or family's condition.
that's
I think
really
lack
good.
of access speaks a lot to exactly what Janani was just saying.
Yeah. And I really like that you've put it as lack of access, so it's not individualized in the same way. And so you're already addressing all multiple layers that might create the experience of vulnerability for someone.
Oh, great. Lots of great answers.
More likely to experience symptoms. That's interesting. So do you mean like within, if they have an illness, that their symptom burden is greater and therefore that might create an extra barrier or extra experience within that person's life? Underrepresented communities. Really good.
I'm just going to go through and answer. So these are answered, so we can come back to them as well later if we need.
Thank you. Old people, women, children are vulnerable. In this context, though, people of colour and people living in underdeveloped countries or coming from underprivileged backgrounds. So,
yeah, that relates a lot to like structural violence, right? Yeah, that's a
great. That's a really, and it relates to, I guess, in the Equality Act, who has been characterised as protected groups. And it's interesting that we're putting specific groups in it as well, and like understanding why we might be doing that. And is there other reasons why people might be, the people within these groups might be vulnerable? People who don't have the capacity to look after themselves or understand treatment, like children. So it's like understanding your own abilities within society.
Yeah, these are great.
Yeah, thank you guys.
Yeah, thank you. I'm really impressed with your answers. Excellent.
Yeah, so if we go on to what we found from the research.
The results.
Oh, sorry, if you wouldn't mind just going back one slide, if that's okay, Caroline, on the vulnerability. Thank you. So we just found that there's actually not like one single definition of this is what vulnerability is. It's a transient, dynamic situation that is built by processes, relationships, structures of power, structural violence that we spoke of before. But also it's really important to see it as a place of potential and agency. It's where people have built resilience, where people have learned to adapt, and they are very important parts for us to understand to then create health systems and healthcare that actually reduce barriers for people, but using people's own methods. Sorry, Caroline, if you go to the next slide. So I think we're running a little low on time, so I'm just going to very, very quickly do this and we'll skip the case study. But these were the results that I got from my study, and it's split into these 6 themes, and each of these themes relate to a different layer and different process of vulnerability. So with programmatic scenes and scenarios, that's how health services are developed, who makes the decisions of what the health services are, where is the funding coming from, and how all of that then creates inequality or difficult access, and how that might then present as vulnerability. But it's also important to remember that it's not just the top-down approach. People are also part of creating the structures of societal structures as well, and so that in itself can be another layer to add to that definition of vulnerability. I just wanted to focus on this slide, not because it was a big part of the research, but because I think it's a really important part in research, and especially anthropology, where you as a researcher are a big part of what the outcomes will be. So what I found as the limitations in my research, it was because there was a lack of literature, a lot of the same authors came up within the papers that we found. So that can create bias. And then secondly, my own positionality in the global north. So I had to use reflexive practice to understand what my biases were and to keep reiterating, looking at the theory and the data to ensure that that doesn't affect the outcomes. And then also because this research was limited to English language papers, there's data out there that I haven't been able to access on NTDs and vulnerability, that because it's limited to English language we haven't got. But we might just leave it on a quote and then open it out to Q&A.
So I want to say, Janani mentioned a case study which we really wanted to go into because she found it really influential in her research. I've put the paper in the chat, so you should all have access to that now. And I don't know if slides are shared afterwards, but we're more than happy to share any information, or we have our emails, so get back in touch with us and we can continue this conversation. So yeah, questions, basically. Sorry we ran a bit over, we got excited, I think, and your answers were so good, it led to some really interesting thoughts. Yeah, I was thinking this is a really good question. I wish I'd prepared a bit more on structural violence in advance. Great question. So I'm actually going to kind of flip it back to everyone else before I answer. But so structural violence, you can think a lot about structural inequity. The reason we use violence is because inequity can be violent, right? So can you think of any structural inequities that affect young people? What about cuts in government funding to youth programs? That absolutely is a huge detriment to young people, to their mental health. And it's a huge inequity against young people living in a rural area. That's great because there's a lot less access to things for young people in rural areas. Really good answer. So I think if structural violence, if you can replace the word violence with inequity, that might help as well conceive of this concept, because it's just saying that inequity can be violent and is actually violent. So colonialism has a violent legacy on people. Financial inequity can be violent against people. So it's actually a term from Paul Farmer, and he's taken it to say he's the one that said inequity is actually violent. So again, I really encourage you to read Paul Farmer. If you were to Google Paul Farmer and structural violence, there's some really great papers and thinking out there. I don't know if that answered your question, if you can let me know yes or no, but otherwise we can think of some more examples. But living in a rural area, and I would say it's not because you live in a rural area, it's what are the systems in place that disadvantage you from when you live in a rural area. Okay, great. And read Paul Farmer if you want more on structural violence.
So hopefully you found this talk really interesting. Thank you once again, Caroline and Janani, for giving up your evening, talking to and educating us about this really interesting topic and your experiences of how working in this area as well. Is a very different kind of topic that we've had previously, so it's been really interesting. So thank you.